Okay, so good morning po. I'm Dr. Wagan po of Makati. So I'm going to present to you our census for hepatitis B and C. So actually, Doc, i-present ko rin yung B kasi kasama siya initially dun sa ating napag-usapan. So total patients namin sa Makati who are enrolled sa na PLHIV is 1,053 based sa August na ART registry namin on the first week of August this year. So basically, PLHIV namin is 1,053. HBV co-infection is 19. So define siya na all PLHIV patient with HBV co-infection, which is HBsAg reactive. For hepatitis C, actually, Doc, 20 yung co-infection namin with hepatitis C. So all PLHIV patients with HCV co-infection, anti-HCV reactive yung sinama namin dito. So first for Hepa B co-infection. So Hepa B, total number of SIL patient with HVB is 19. Pag triple co-infection, wala po kaming nakita with HIV, Hepa B and Hepa C. This is the census of SAIL Makati, yung total. Nakaayos lang siya dun sa HEPA profile. If meron din siyang concomitant HEPA C. Nilagay ko na lang din dito if yung mga liver enzymes, if nagawa ba yung HBV DNA, current regimen for HIV, if latest viral loaded and CD4, and the status sa amin sa clinic. So, we have total of 19. So basically, we get the hepatitis profile at the baseline laboratory with HBsAg, anti-HBC, at saka anti-HBs. So treatment-wise, HIV, HBV co-infection, so we initiate the ARV regardless of the hepatitis status. Kasi since naman ang basically binibigay namin initially for treatment for HIV is tenofovir-based regimen. So for monitoring, we monitor the hepatitis profile annually from the baseline. Liver enzymes, we monitor it every 3 months dun sa routine. And then actually HBV DNA was not part of monitoring, but ideally at 3 months from initiation if positive siya for HBsAg. So this is just a summary of the interpretation. IgM anti-HBC BC is not included in SAIL Makati's current HEPA profile. So for preventive measures, what we advise our patients in SAIL Makati is that we advise them to have hepatitis B vaccination if HBsAg non-reactive, anti-HBs non-reactive, saka anti-HBC non-reactive siya. So hepatitis B of 40 na 40 ml siya, tapos at 0.16 months. So, we included lang yung vaccine. Pag humingi yung patient, for example, for DSWD, we include siya dun sa prescription. And then, we also have a sample of the vaccination card, pero hindi pa namin siya nagagamit currently sa SAIL Makati. So, for hepatitis C co-infection, total number of SAIL patient with hepatitis C is 24. We also have a census for patient na naka-prep pero may positive for hepatitis C. We have total of 4. So for hepatitis C co-infection, we have 20. So etong census na to, ginawa lang namin is I included the liver enzymes, HCV RNA if done, genotyping, if enrolled to treatment, current HIV regimen, sorry, and yung latest viral load tsaka CD4. So out of the 1,053 patients, 20 patients are reactive to HCV co-infection via anti-HCV. And then 7 patients out of the 20 have their HCV RNA done. But out of the 7, 7 out of 7 patients have HCV RNA not detected. 0 out of 7 have showed HCV RNA detected, and then 1 patient was enrolled even though he was not the HCV RNA was not detected. So for the case discussion, so we have EHM25, diagnosed with immunocompromised host since October 2022, asymptomatic with initial CD4 of 175. So pertinent past medical history, have a malaria last 2018 and history of blood transfusion during his admission because of malaria. Personal social history, non-smoker, occasional alcoholic beverage drinker, denies illicit drug use, IVD, and intranasal. Sexual history, bisexual, concordant couple, sexual habits, oral sex, anal insertive, and receptive. So for the baseline laboratory prior to the initiation, normal X-ray, CD4 175, and then on baseline, anti-HIV reactive. So our problem list at that time was HIV. So we started the patient on TLD. We started also the patient for IPT and contraimoxazole for PCP and toxoplasmosis prophylaxis. And for hepatitis C, we advised the patient for HCV RNA. So during the course, patient opted for second opinion and was seen by a gastroenterologist at St. Luke's. The diagnostics done, reactive for anti-HCV, HCV RNA not detected. ALT was noted to have elevation during the first three routines in SAIL Makati. No imaging was done. Patient was given sofosbuvir 400 plus velpatasvir 100 tab once a day for 12 weeks. So this is just a graph that shows you the elevation of ALT and AST during the intensive phase of monitoring in SAIL Makati. So patient had elevated AST at routine 1 to 3 and then AST at routine 1 only. But eventually, nag-normalize siya below the 50 na normal value. So, unfortunately, patient did not follow up with his gastroenterologist and did not complete the treatment for HCV due to financial constraint. The patient only had 1 month was only on 1 month treatment for hepatitis C. So our plan is to repeat the anti-HCV after 1 year. So how do we approach patients with hepatitis C co-infection in general? So all people with HIV should be screened for hepatitis C infection. Patient at high risk of HIV infection should be screened annually and whenever incident of HIV infection is suspected. So this is our approach for hepatitis C in SAIL Makati. Regardless if you're a PrEP patient or HIV, consultation at done during initial visit of the patient. So we screen for high risk of history of unprotected sex, of use of sex toys, person who inject drugs, or concurrent STDs. So we request for the anti-HCV if there's a presence of which is presence of HCV antibody. So if non-reactive siya, we monitor if pag HIV monitor from baseline and then every 12 months. If reactive, we advise for HCV RNA and genotyping. If the HCV RNA is detected, we automatically go for genotyping because we base the regimen for hepatitis C treatment based on the genotype. And then if the HCV RNA and genotyping is reactive or not, we monitor and refer to a hepatologist for co-management. And then treatment will be given by the hepatologist. So for the risk factors, these are the list of risk activities and risk exposure for hepatitis C. So injecting drug use, so current or ever, including those who injected only once. So intranasal illicit drug use of gas crack pipes, male engagements in sex with men, so engagement in chemsex. So for risk exposure, persons on long-term dialysis, persons with percutaneous or parenteral exposure in an unregulated setting, healthcare, emergency medical, and public safety workers after needle prick, sharp, or mucosal exposure, HIV-infected blood, children born to HIV-infected women, and recipients of prior transfusion or organ transplants before July 1992. So this is the sample referral that we give our patient if the patient is anti-HIV reactive. So we attach the result plus we give a letter and then we advise them to go to NIH for HCV RNA or any other lab test or diagnostic centers. So for diagnostics, establishing if the patient had current HIV infection. So basically HIV antibody. If non-reactive, we stop already for the diagnostics. If reactive, we go to HCV RNA. If not detected, there is no current HIV infection at the moment. So there's no additional testing. Or if there's additional testing, we request for imaging. So HCV RNA, if detected, um, there is current HIV infection and then linked to care. So do you still test HCV RNA to a person with non-reactive anti-HCV? Yes, you can in certain group, which is immunocompromised host. Exposure to HCV within the past 6 months because anti-HCV may still be negative on the first 6 months. I'm sorry. For the natural course of HCV, um, technically, there's a patient who is reactive to HIV, mas mataas yung chances of advancing ng liver cirrhosis if may co-infection siya with HIV. Kaya prompt treatment is warranted. So natural history of HIV infection, exposure, 15% will resolve, 85% will go to chronic hepatitis C, 80% will be stable, and then 20% will progress to cirrhosis. 75 of that will be slow progressive and 25 will go to HCC. So patient who test HCV RNA positive should undergo HCV genotyping and liver disease staging as recommended. So genotyping the reason for genotyping is that we basis siya for regimen and duration of treatment, and the liver disease staging to assess if the patient is cirrhotic or if already had complications. So I just summarized the treatment plans if you have an HIV reactive or current if the patient have a current HIV co-infection. So on the first table, you will see that we included genotype. So kung pan-genotype siya, 1 to 6, so ito yung regimen lang na available. So in our patient, ang binigay is a fosbuvir 400 plus velpastavir. Ang dosing niya is 1 tablet once a day. If without cirrhosis, or without cirrhosis, 12 weeks siya. So these are the other primary treatment for hepatitis C co-infection. So, yan yung primary. And then, this is the alternative treatment based on the genotyping. So, we also base the treatment if the patient had cirrhosis or with or without cirrhosis. Nakadepend yung duration of treatment dun sa if may concomitant cirrhosis yung patient. So HCV, HIV co-infection, so the rate of progression to cirrhosis and risk of HCC are increased, even the rate of HIV progression is more rapid. So some important drug interaction if you have HIV and HCV, lidapasvir or sofosbuvir should not be used with combiscat when given with tenofovir or tenofovir. So partitabravir, ritonavir, and ombistavir plus dasabuvir should not be used with darunavir, efavirenz, ritonavir, boosted lopinavir, or rilpivirine. So simiprevir can only be used with selected ARV, raltegravir, rilpivirine, maraviroc, tenofovir, emtricitabine, lamivudine, and avacavir. So RVV should not be used in didanosine, stavudine, or zidovudine. So yun lang yung mga drug interaction with HCV, HIV medications. So, for response to therapy, so they have a term for that. So, end of treatment response, undetectable at the end of treatment, relapse if undetectable at the end of therapy but rebound or detectable virus within 12 weeks after therapy is stopped. So sustained virological response, ibig sabihin, cured, so still undetectable at the end of the therapy and beyond 12 weeks after therapy is stopped. So for preventive measures, so harm reduction, avoid sharing of toothbrush, dental or shaving equipments, avoid reusing or shaving syringe, and use of barrier precautions to prevent sexual transmission. So avoid hepatotoxic drugs, use of excessive acetaminophen or certain herbal supplements. Alcohol consumption should be counseled to avoid consuming alcohol. Daily consumption of more than 50 grams of alcohol has a high likelihood of worsening fibrosis. So for hepatitis C census, so percentage of from the total PLHIV who are co-infected with HCV is 1.8%. This is for sale Makati. HCV RNA percentage of HCV PLHIV who had HCV RNA confirmatory testing done 35%, and then HCV RNA not detected 100%, and then HCV RNA detected is 0%. So yun lang po. Thank you.
Thank you, Russell. And we presented this case because you had a bit of some dilemma, no, during the course of treatment. And can you identify what the dilemma was?
Since the patient is HCV RNA not detected, but the hepatologist na nakakita sa kanya, trinit pa rin siya for HCV. Based sa guidelines, hindi ka na, magsa-stop ka na if HCV RNA is not detected.
Can you show the algorithm yan? Okay, sige. So, ito yung sinusundan natin na parang guide para malaman natin yung next steps. And what Russell is saying is that after doing the HCV RNA and it came out not detected, ideally, you would conclude that the patient does not have current, no? Pwede siya nagkaroon ng past, pero nothing for the current, and therefore, this patient, supposedly, according to the guidelines, ay kailangan na lang i-monitor on an annual basis if kung magkaroon man siya. So, one of my questions is, number one, ano kaya ang reason for the insistence on treatment? And then number two is, ngayong nabitin siya sa treatment, so parang incompletely treated siya. Pag bumalik siya, knowing na yung kanyang anti-HCV was initially reactive, what's the mode of monitoring the patient now? Will it be still another still another anti-HCV, or dediretso na tayo sa RNA on a yearly basis? No, may cost implication din kasi to. So we have to kumbaga project, no, among the patients, the seven clients ng Sale Makati who tested reactive but did not have a viral load, are all of them now going to have annual viral loads? Kasi mag-a-adjust tayo ng ating budget on. Yan. So those are my two main questions. And it is at this point in our meeting wherein I'd like to call in our special guest to share her insights on our questions regarding the case. So Doc Edel, do you wanna share?
So thank you for the case. I think Dr. Russell was our resident. Tama ba, Russell? Sa TMC.
Yes, before.
So small world. You're correct. Dr. Russell emphasized important points in his lecture. In patients with co-infection, they're actually a focused population that in terms of policy and as a healthcare provider should be prioritized for treatment. Kasi number one, they are at risk for worse disease, and that includes a higher chance of developing liver cirrhosis, thereby a higher chance of developing liver cancer later in life. And number two, they're a high-risk population in terms of transmission, no, because of risky behavior. So that's one. And yung concern sa case, I am actually unclear. No, baka something lost in translation with the discussion of the physician with the patient. But you are correct, Dr. Wagan, na if the patient is RNA negative, then that means an anti-HCV positive. Ibig sabihin, that means a past resolved infection. So patients with HIV who get infected with HCV can still get spontaneous cure. No, it's less, no, parang minsan they quote values na 15% lang yung spontaneous yung magre-resolve, but it's not impossible. And for patients who achieve spontaneous cure, they do not need antiviral treatment. So yun. Do you have any, baka may gusto mag-clarify sa audience before I proceed?
No, I
Or
think
can,
that's very clear. Although I do have a question. So,
go ahead.
think of the value. So, what do you think of the value of repeating an initially positive anti-HCV in a more
Negative
specialist,
RNA.
sorry, someone who tested positive for
There is no need.
anti.
If it's RNA negative, and then unless siguro you doubt,
No, sorry.
I will.
Oh, sorry, wrong question. Let me clarify. If the antibody result was positive, but you wanna be extra sure without doing an RNA agad, just for cost implication, and gusto mo siyang ulitin in a more reputable lab, do you think we should do another anti-HCV RNA muna? I used to do this before, no? Ang pang-confirm ko is like the PGH lab. Sabi ko, okay, ulitin ko muna sa PGH yung anti-HCV until I decided na let's go straight na lang to the reputable lab. So for anti-HCV so that we skip this uncertain step. Just because of baka false positive sa lab nila, baka hindi up to date. Alam mo yun, mga ganun bagay. What do you think?
I think there's no need, no? The only reason siguro that I would consider doing that is kung halimbawa may something unexplained. Like the clinical course, you have no other explanation for a very high ALT and AST, very clearly with exposure and risk factor. Halimbawa, patient recalls risky behavior in the past few months with someone known na Hep C positive. Pero a nucleic acid test, no, that includes yung mga RNA testing, gene expert testing, should be sufficient enough for us to rule out na parang this patient is a past infection. But in this case kasi, since you're dealing with a high-risk population, for sure, pag anti-HCV positive, you will need to repeat your RNA every year. You have no choice, no? There's no need, the other thing na naisip ko na possibly you can save on is yung genotyping. And that's because we have very limited options for antiviral in the Philippines naman. And what we have generally is Sofvel. Meron din Sofdac, but out of pocket, that is a more expensive option. And these regimens are generally pan-genotypic. And swerte tayo sa Philippines, as you saw in your data, that mostly were genotype 1. So genotype 1 is much easier to treat, less problematic. Tapos even in the early phase of the DAAs, less yung chances ng treatment failure, and also yung disease progression is less. So that's one way. If there's a cheaper nucleic acid test, you can go with that. No, pwedeng basta ang norm lang po kasi basta anti-HCV positive and detectable yung RNA, treat na yon, especially in the context of co-infection.
All right, okay. So, in summary, we can skip the genotyping because what we're gonna give anyway is gonna be pan-genotypic. So,
Yes.
when we catch someone with a positive RNA, enroll na namin into treatment. Skip na natin.
Yes.
Although it would be
Kung
nice.
kung Sofvel.
Right,
Although
Sofvel.
pan-genotypic naman siya eh.
I mean, alam mo yun, for epidemiology, it would be nice to know. Like, baka
yes, you're correct. Tama. Kasi there is a sprinkling of genotype 3, no? So yung mga may sa South Asian or travel to South Asian, Southeast Asian continents, no, na in the part of the continent, pwede kasi. Pero theoretically, the chances of cure for these patients na Geno3 are still relatively high. No? So, kung nagtitipid, yun talaga yung option. What I don't like to skimp on though is yung baseline assessment of fibrosis. Kasi even with hepatitis C cure, kung may cirrhosis na yung mga patient na yan, na they can have physically no symptoms, no, you can detect no symptoms. In these patients, you still need to enroll them to a liver cancer screening program, which means ultrasound every 6 months for the rest of their life, together with at least maybe alpha-fetoprotein or other liver tumor markers. And I think that's important kasi as you notice din kasi yung mga may HIV, HCV co-infection, hindi lang Hep C and HIV yung liver risk factor nila. They also have fatty liver, alcohol. So these things I think are important aside from treating the Hep C to catch the patients who need to be screened for liver cancer, no, and advised, no. Yun. Tapos isa pa, which I also noted dun sa case, no, one important point is if patients will go out of pocket. Kasama sa initial counseling ko actually sa kanila yung if you go out of pocket, ganito po yung estimated amount. And then I tell them, do not start treatment or do not buy treatment until you have yung 12 weeks. Pag-ipunan mo muna yung 12 weeks. Kasi nakakatakot na we breed resistance in patients na hindi nila matatapos yung treatment course. So I tell them, kung hindi na mahihintay yung government supply and you want to buy your own, make sure na mapag-ipunan niya na po yung 12 weeks, saka tayo mag-start.
Yeah,
So parang oo. So minsan we have to get creative with these patients. Parang recently there was a patient who asked, "Dok, pwede bang credit card?" So I had to talk to the drug company kung meron ba kayong access points na credit card para at least they can parang deferred payments, no, and yet buy the whole 12 weeks. So parang that is another point na we can consider kasi many of these patients naman are working and willing to parang kasi overall the chances of cure is like over 95% generally. So sayang.
right. So in this case, Edel, since there's no RNA naman, there's no chance for resistance, right? The virus is not around.
Yeah, wala naman. Pero
Swerte.
sayang ng pera, oo. Sayang ng
But
pera ng patient. So hindi ko alam. Oo.
Okay, in lieu of the fibroscan, which we know is a bit pricey, the
Oo.
ultrasound can be the ultrasound combined with
Free, yeah. So you can at least get an ultrasound, siguro liver ultrasound. And then you can, with an AST, ALT, and a CBC with platelet count, you can compute your APRI, also FIB4. So may online calculators yan. You can, parang if you have EMRs, no, it's something that you can have open in your browser. Enter mo lang yun. That's their cutoff values for cirrhosis and advanced fibrosis na usually will already be in the calculator site. So kung walang funds, at least yung mga yun. Oo. Also important to rule out na may concomitant Hep B. So although usually naman tenofovir is in the regimen, just in case may maligaw kasi sa inyong mono-infection, ang Hep C kasi kung co-infection with Hep B, what happens, iti-treat mo yung Hep C and then the Hep B can flare. No, so that is an important thing to consider. Parang your immune system suddenly picks up on your Hep B once ma-cure mo yung Hep C. And in a patient with underlying liver disease, that can be catastrophic, even fatal, if they get a Hep B flare on top of underlying cirrhosis. No? So yun. I think that's it lang.
Oh, thank you so much, Edel. We learned a lot today. And fortunately, Russel, wala ka pa namang active na Hep C undergoing treatment, no? Tama ba? Kasi 7 are RNA negative, but we're still waiting for a few who have yet to do viral load. Tama ba? May viral load ka pa eh. Ayan no, not yet done. Ang dami,
Ang
ang
dami
dami
pa
natin
po, Doc.
gagawin.
Dami.
Yeah, so let's make that a priority. And I do understand that it's
Wait,
kind of
let me check I think yung lunti ang silong, I will check if they have gene expert. Sobrang ano kasi may DOH is trying to fix that.
okay.
But for the past 2 years, there's been a asynchrony of stuff. Like, may sa Fosbovir, walang Daclatasvir. Minsan may gene expert for Hep C RNA, pero walang gamot. So, parang inaayos naman na nila yon. They're trying to fix kasi biglang napasa to another group yung hepatitis. Let me check kung saan nga ba yung site na nagsabi nila may Hep C gene expert sila for free sa treatment hub.
Wow, sige please.
Oo.
Is it in Region
I'll check.
3? Region 3 ba
Yeah,
siya?
Region 3 yan. So,
Okay,
yun,
sige.
hindi rin kasi mamap Baka in your discussions din with DOH Central Office, that's what
You
we've
know,
been
I can
asking them. Nasan ba po yung gamot nyo? And nasan ba yung mga gene expert cartridge?
let
Para
me
kung
ask
hindi nyo man
the
ma-distribute, we can shunt the people there when we pick up these patients. Oo.
right. No, I'll ask the regional HIV coordinator because I think siya rin yung in charge sa hepatitis.
Malolos. Oo. Oo. Not
Ano,
sure who it is
ano,
now.
si
Si.
ma'am. Si ma'am the
Ah,
girl.
sige.
Tanungin ko. May pahabol tayong
Okay.
question. Okay, hold on. For those not on treatment yet who have Hep C, how often do we monitor for liver function test, cirrhosis, HCC screening? Yan. Kung hindi pa, kunyari waiting ng treatment, but gusto na nilang tignan yung liver function and risk for cancer, how often should it be done?
That will depend on what your baseline. So get a baseline po. If your patient is cirrhotic, number one is to check kung decompensated ba siya. So decompensated means naninilaw, may tubig sa tiyan, no? So may ascites, as well as may bleeding. No, kung compensated naman, I guess there's the option to monitor every 3 to 6 months. At the minimum, every 6 months. Kasi yung minimum of 6 months is for liver cancer screening. And that is with liver ultrasound and alpha fetoprotein. For liver function, at least get a baseline, no, for these patients, no, and that will include yung fibrosis, whether by fibroscan or APRI score or FIB4. No, these are online calculators that you can use using AST, ALT, and your CBC platelet count. So at least yun yung baseline. The other important thing pala before I forget is to check baseline kidney function in these patients because our regimens have tenofovir, yung antiretroviral regimens have tenofovir, and the regimens for Hep C treatment have sofosbuvir. So sofosbuvir will increase your tenofovir levels. So ang risk nun is yung nephrotoxicity. So you have to watch them lang na hindi mag-worsen. Most patients naman kaya yan, except lang kung may baseline na CKD, yun yung mga babantayan mo sila. Oo.
All right, thank you.
I
Thank you,
hope that
Edels.
answers it.
Yeah, it does. So usually these are part of their quarterly tests, except for, so guys, remember, usually you don't check the platelet. So for those who have Hep C patients, please include platelets in your CBC. It has to be indicated, CBC and platelet. That's an extra 50 pesos. That's fine. And then you can do the APRI score. Therefore, you will need your AFP and ultrasound as part of that at least baseline for your Hep C. And then the
For
frequency.
APRI, Kate, ano lang, AST, ALT. Sorry, Kate.
Platelet, no
AST,
na.
ALT lang. For APRI.
Okay.
And
All right.
AST,
So,
ALT, and platelet. For APRI and FIB4. Liver
right.
cancer screening only for cirrhotic.
Okay.
I'll summarize
Got
it and send it to you siguro.
Okay. So the only thing we need to add pala is the platelet. kasi all the rest you're already doing on a quarterly basis, at least at the beginning. So, and then if you determine if your patient is cirrhotic, that's when you proceed to yung AFP. But we'll send you the tips ni Dr. Tripon so that you can monitor your clients while waiting for your medication. So, next important step is for us to determine where we can send our clients to do their HCV RNA for free, because look, no, how many pa ang waiting ng RNA sa SAIL Makati, and those who have already and are due for treatment is to follow up on when we can expect the free meds, or if there's no free meds, let's come up with a solution to help our patients purchase their medications. No. And of course, while they are infected, let's apply the prevention measures enumerated by Dr. Russel. All right, sige. So, any other questions from the group before we end today's very interesting case? Okay, if there are none, I'd like to thank Dr. Russel for sharing with us ang kanyang very interesting case, but very important conversation and discussion about hepatitis C and B as well. Hopefully, we can also get some sort of summary of our cases just like this para rin mabantayan nyo yung mga hepatitis co-infections natin. Also, thank you to Dr. Edel Tripon for allowing us to get a lot of her time today. Buti na lang you're on the road. Wala kang choice kundi sumali sa amin. She's very busy. Thank you. And guys, if you need to refer to any of our past Hep C and Hep B lectures, I shared with you Dr. Tripon's lecture. And later on, if Russell will allow, we'll also share the recording of his discussion today. So thank you once again. And until our next case presentation, have a great day. Bye all.